come back. Just give us a second with technical stuff.
Yeah, actually, would you just bring that over? Sorry,
You just need to plug in here really quickly.
this is a computer. Thank you. I appreciate it. Good. All right, for the record, Noel Langwell, Joint Fiscal Office. I've been asked to just come and just kind of refresh folks on what was in my fiscal note. Another second here, find the fiscal note. That's good.
S63, 53.
53.
Sorry.
63 is what we just did across the hall.
Yeah.
Uh, there it is. All right. So we talked about the per diems. There's section 1 of per diems, those are nominal. There's licensure fees. I think there's 4,500 to 7,500. I think that's not what you want to hear. I think you want to hear about the Medicaid fees. So a couple of thoughts on the Medicaid piece, and sorry that I missed Diva's testimony, but I did talk to Alex a little bit, and I want to address two of their points. One is the lack of funding for Diva. So they testified S53 does not contain an appropriation. That's because the bill doesn't take effect till 2027. Their concern is that we are obligating future legislatures. I think that even regardless of whether, well, first of all, we can't appropriate for 27 because we're not doing 27 yet. But the second, it just kind of ties into the second point about the MMIS, concerned about the time it takes to do MMIS and getting the state plan amendment. If we passed this bill this year, it couldn't take effect till 27 at the earliest because they have to do the IT changes, because we have to get the state plan amendment. So even if we wanted to take effect in 26, it wouldn't. So I think that was the part about being at 27. If we were to postpone it a year, then it would still be that year gap. So no matter what we do, there's going to be that gap in year because of the time it takes to get the MMIS. So that's a concern that, he's right in that we don't appropriate for 27 and out years. But it's not uncommon for us to pass legislation knowing that we need state plan amendments or knowing that sometimes they take time to go into effect. So to the extent that this would, if the legislature passed this and then the governor signs it, that's his commitment to funding it in 27 and including in his budget that he would propose in 27.
So I think the point is no matter what you do under Medicaid, anything that requires
This.
a state plan amendment is always going to be a future legislature is going to make the determination on the appropriation. Because you can't possibly.
Yeah. Sometimes we, assume, we think it's going to take 6 months, but we know that things are taking longer now and we're in an unknown environment. So even if you were passing this, even if everyone was on board, we'd still want it to be a year out because we want that gap.
Mhm.
Now, the other piece is that I think it's important to sort of reiterate what those costs will be in the first year. And there was, when David did their, when they provided the estimates for this, they talked about how the maximum cost of this could be around 1.3 million. But that's an out year. It's nowhere, in no state has there been large immediate take up on this. It's going to take time. As a matter of fact, in states that have done this, I think I talked about this, there has been some lag in that because people don't know it exists. They have to get the word out. So it's going to take some time to do that. So, and utilization, I was saying this offline earlier, people on Medicaid, people in general are going to get pregnant regardless. So we're not driving utilization towards this, towards doulas. People are going to get pregnant regardless of whether they have access to doula services or not. And I think the research exists that doulas can save money and that it is cheaper to use a doula than to go to the hospital in a normal circumstance where there's not an emergency situation. If there's an emergency situation, then they absolutely go to the hospital, but they probably would have had that regardless. So I am generally not one who would ever come in and say the savings would be immediate. I've been pushed before when we do smoking cessation. We book those savings in the first year, and I said, no, there's going to be savings, but you can't book it. In this case, you can't book it, but I think you can. And when Diva, if I were the Diva finance person and I had to build a budget, I might not be able to build. I would have to ask myself, can I book those savings to offset? And the answer is, I'm not sure how I would do that. So I get that point. But I think it is fair to say that there would be some cost offsets. And that, so the utilization and the cost in the first year is not going to be full, it's going to be low. And that there would be some offset savings. So that's what I have to say.
And so the 1.2 million that they told us today is like the
Absolutely.
absolute highest number years away.
I don't have the number, the estimates in front of me because I didn't bring that folder, but there's like a high end, low end. And I don't know what that builds for utilization, but that's definitely not a low end.
Okay.
The low end, I think in my fiscal note, I assumed like a 10% utilization. Let me see if I can find it.
I think it's in their testimony that they provided to Senate Health and Welfare.
Yeah, I think, and again, I wasn't prepared to talk to this, otherwise I would have had my notes in my folder. But I think I assumed, a 5 to 10, or maybe even a 1 or 3%. I don't remember, but I assumed a lower utilization and uptake in the early years. And, if it all goes well, you would hope the uptake would be increased in the out years. But so I think the 1 to 3 is a more like assumes that a large number of people are going to be using it immediately. And that's, given the experience of other states that have done this, I find that unlikely.
10% is 426,930.
Yeah.
10% utilization.
Yeah, so I think I assumed that. And that's 176,000 general fund, 426. And I think that's the high end for the first year. If you look at how many people are on Medicaid. But I think that's what I would, if I were the CFO of Diva and this went into effect, that's probably where I would do it in the first year. But again, I'm not them, and the person who does that job is very good, so I would never tell them how to do this job.
And Tucker,
Nolan, just so I'm clear, you did 176. Did you?
General fund.
Yeah. Did you say that would be spent 26?
No, the first year that this went into effect. Assuming that we get SPA, the Safe Fund Amendment, and the IT system in the first year, assuming a 10% uptake, which I think is a fair assumption, may even be on the high end for the first year. That's what it would cost the first year. But this bill will not take effect in 26 because the language specifically says 27.
Yeah. Okay. Now, in 26, OPR has to spend some money, right?
Yep.
25 grand.
Yep.
So that's what we're talking about, 26.
Yep, and that's in the budget. It's already been agreed
It's already
to.
there.
It's actually been agreed to by both House and Senate conferees.
all right, oh, Woody,
So based upon your conversation with Diva, has Diva changed their thought process? They're still negative towards this bill?
I will not speak for Diva's opinions on this. I had a very good conversation with them. They provided some very good information. They provided the information for me to make these estimates. I would never say on the stand how someone else feels about a bill based on a conversation.
But we were briefed earlier that they could not support.
Yeah, and I had this conversation with them before they testified as well. So I'm not going to testify to someone else's opinion, regardless, even if they're sitting here and said it. I would say they said it, not me. It's just more.
So I guess we'll have to, hopefully I'll see.
I think the answer is that you have to talk to them about their policy position on this
Okay.
and their justifications.
So I'm assuming they haven't changed that.
I would assume they probably have not.
If they had changed, they would have asked to come back in. Um, Wendy,
Just, I'm new at this, but if you're saying this is not gonna materialize until 2027, do they still have to put something in? For the budget?
No.
So that was really their argument, correct? Is that?
No, this is about, what's in the budget is the OPR money.
Mhm.
So in order for them to, OPR to regulate it, they need a one-time to sort of get their systems and things to be able to regulate the actual doulas. The 27 costs are, once we allow Medicaid to cover it, we have to pay Medicaid claims to cover it. And so that's what they're saying. They're saying, okay, well, now we're gonna have a new service that we're providing and we have to do claims for. So that's what that 127 or 476
Which
is.
would not materialize in 2026 at all.
No.
And that seemed to be what they're.
No, their concern is that we're obligating a future budget,
Okay.
which is a fair argument.
Mm-hmm.
doesn't every expansion of
Doesn't have
every
to be here.
coverage,
Mm-hmm.
Sorry, and I probably missed
Yeah,
this,
Laura
but I just want to
skipped it.
clarify. OPR is saying that they want to certify, even if we don't do the Medicaid eventually, or is it all tied together?
it's all tied together.
Okay, because they wouldn't just certify it anyway for those who aren't taking Medicaid, but just want to be certified. That wasn't part of the,
Didn't come up.
okay,
That didn't come up,
okay, thanks.
like the separation of it.
Okay.
Because they really felt, and they gave numbers.
Yeah,
That
I
it was
heard
the,
all that.
that it was the Medicaid population,
Yeah, which isn't very important.
which is very important. Thank you, Nolan. Thanks so much for
Thanks,
making
Nolan.
time for us.
Always.
So I've asked, I'm sorry, I'm not quite looking at my schedule, so I'm not sure.
Amy.
Come on up.
Amy and Sarah.
We just added them. Amy, I knew Amy. Come on up, Amy.
Hi. Hi.
You're welcome.
Thank you. Amy Johnson, Vermont Care Partners. I have nothing prepared, as I didn't know, but I'm here to answer anything that would be helpful for the committee related to doulas in this bill. And I will say that I have actual doulas with some really great data in the room as well. So,
Can we have Sarah come up?
Can we have Sarah come up?
yeah.
And I'll be perfectly candid. We took an enormous amount of testimony on doulas last year, which is the Sunrise report is the result of all the work that we did on doulas. So when we were doing this bill, I was very limited on testimony. Just wanted to make sure that the affected agencies or departments and that everybody understood what a doula was, but maybe we can have a little bit of testimony on some statistics and things like that. Mari, go ahead.
Yeah, that was why I was hoping that you could testify today, was specifically to get to the point of data around costs.
Yeah.
Savings, and that are they immediate savings or are they savings a year down the road?
Yeah, and so I'll start with kind of from the mental health perspective. So, and then I'll toss it over to Sarah because she can speak to some of the physical health care savings, and those are both being much more immediate. But so there are two designated mental health agencies that have community-based doula programs, and I think there's a variety of reasons why we decided to do that, but what I will say related to data is that at NCSS up in Franklin County, why we started that program was because we were seeing really high rates of postpartum depression. And the visiting nurses were bringing that information to us as a mental health agency and said, what can you do to help? So we used home-based clinicians and then added a doula component. From there, and I don't have the data with me, but I can show you that program-specific data of how we turned the curve on rates of perinatal depression in that region. But one of the things that was happening alongside that process is we had a 5-year federal grant related to screening and treatment of perinatal mood disorders. And one of the things that happened through that 5-year grant was that Mathematica came in and gave Vermont specific data around the cost of perinatal mood and anxiety disorders to the state of Vermont. And I think that that's really compelling information because it is not national, it's Vermont, and it's very recent. I believe that the information is from 2023. I will send this to you so it can go up on, but I have it here. I don't have it. I used to have it memorized. So I'm going to just let you know that for Vermont, it costs $48 million annually. Perinatal mood and anxiety disorders in Vermont. The cost, $48 million it costs the state in untreated perinatal mood and anxiety disorders. So that's huge. That's a huge statistic. I'm going to look at my phone because I need my cheat sheet. And they are among the most common complication of pregnancy and childbirth. So I think that that's important to note as well. So when we're looking at kind of drilling a bit more down on untreated perinatal mood and anxiety disorders, for the birthing parent, we see lower labor force participation, we see higher work absenteeism, and we also see increased risk of worse maternal health, and Sarah will be able to speak to that a little bit more. But then we also see, we're looking at kind of the birthing person, but then when we go beyond that, when somebody has an untreated perinatal mood or anxiety disorder, that also impacts the child's health. And so we're now going beyond how that impacts the caregiver, and we're looking at the family and the cost of the family. So we see increased risk of preterm birth, lower likelihood of being breastfed, increased risk of perinatal mortality, which we see as stillbirth, neonatal death, sudden infant death syndrome, also known as SIDS, increased risk of behavioral or developmental disorders. A big piece around PMAD that can happen is we have this kind of, it's really important for that bonding to take place, and that kind of intimacy with the caregiver and the child impacts brain development, and it has long-term impacts, positive impacts on social emotional health. So if you're somebody who's struggling with a PMAD and you're not able to make that connection with your child, that impacts them socially and emotionally, which has immediate and long-term impacts. So that's, again, a cost to the state, because we're seeing those kids in adolescence or into adulthood. And so then I'll just have one more, and then I'll freeze for a second. An increased likelihood of worse child health, childhood injuries, asthma, emergency department visits, and obesity. So this is a long, multi-page study. I'm just giving you kind of the clip notes of it. But again, this was, a professional vetted group coming in and looking specifically at what this looks like for Vermont.
I'm going to send that.
And I will send that so that you have it to look at. And then I have the regional data on how the community doula program, and I know Maria has this for Washington County, lots of data as well, how that program impacted the rates in Franklin. Perinatal mood and anxiety disorders, but some people do not prefer that. Some people say perinatal depression and related disorders, but in the study, it lists it as PMADs.
Thank you.
Yeah.
Thanks for resetting us a
Yeah.
little bit. That was, so. Right, so we're gonna have Jen come up. Oh, I'm sorry, Sarah.
Go ahead.
That's okay. Yeah, I have a few data points that refer to very short-term outcomes. So specifically, they would be within the Medicaid billing
Mhm.
event itself. So really immediate.
Okay.
I'll just say I am a doula and a member of the Doula Association. My name is Sarah Teal. I've also for 12 years been a researcher for Voices for Vermont's Children. And so
through that lens as well, I've been doing the policy analysis and research and data collection on this policy specifically for probably almost a decade now, working with Maria, working with Amy. And so over the course of that time, I've seen this sort of expansion of the recognition of the outcomes and the positive outcomes of doulas. In the earliest days, people were very focused on the immediate medical outcomes. And so there are some really long-standing research efforts focused on that. One of which is what's called the Cochrane Review. The Cochrane Review is probably the most cited long-range scoping study about doulas. And what that study in particular found is that doulas are associated with a 39% decrease in the risk of cesarean, a 15% increase in the likelihood of a spontaneous vaginal birth, meaning no induction medications, a 10% decrease in the use of any medications for pain relief, shorter labors by 41 minutes on average, and a 38% decrease in the baby's risk of a low 5-minute APGAR score, which is the evaluation of the baby's sort of like robustness, right? And so that would be associated with like decisions to admit to the NICU or things like that. So those are some pretty striking numbers as far as I can see. And just to pair that with some like numbers for Vermont, in 2023, there were 1,831 inductions out of the 5,000 or so odd births, 430 NICU admissions, 2,847 births using anesthesia, that would be epidurals, for pain relief, which also is associated, doulas are associated with much less use of, the 10% decrease in use of medications for pain relief. So those things right there, if you group those together, a state Medicaid program could expect to basically realize those, that would balance out, right, in the immediate term. And also just to add, like, there's this number in here that doula care is associated with a 31% decrease in the risk of being dissatisfied with the birth experience. And I'll just put that into a more potent framework of, like, from a doula standpoint, what I have seen in terms of trauma and people's experience of trauma over the course of their labor and birth. I don't know, the numbers, maybe like 30% of birthing people or something like that will say that their birth was traumatic. And anecdotally, what I have seen is that even in very, very difficult situations, when things might otherwise have been traumatic, I have seen people be able to say, but it wasn't actually traumatic for me because of the support that I had. And that just extends into basically your entire parenting experience, especially the early postpartum, but really can go on for years. The value of being able to process things in a way that you feel heard, you feel like you've had agency, and the conversations that you've had over the course of your medical experience have been, you can bridge, a doula can bridge these conversations so that medical decisions are really the best they can be. So as I was saying, like, doulas help the healthcare system work better for people.
Thank you.
You're welcome.
Thanks so much.
Thank you.
Robert, do you
I
have a question?
I don't know whether or not it has any effect at all. But one of the pieces of information that we got was on the deaths and mostly drug related. Does it have any effect at all on people who were abusing drugs or abusing any kind of substance, changing their way of life? Or is that's not being looked at?
What I would say is that the reason a doula is so effective is because a doula exists outside of the healthcare system, right? A doula is an advocate for the person and you have a trusted relationship with them.
Right.
And so I can't say there's a direct, I don't know. And every individual is different. Do you have?
I don't have statistics on this. I would have to look to see, but what I can say in how this plays out in the program at NCSS, again, I think Maria would probably have something similar to say, is we're working with, that program is a universal doula program, so everybody gets one. And so we're building that relationship, and through that relationship, we're able to connect people with services and build that bridge back to treatment, care, and that kind of full wrap. And people are much more likely to accept or be referred and accept that referral into services through that relationship with their doula. We saw that a lot through that program. So I don't have Vermont specific, this is kind of more anecdotal, like how it played out with community doulas on the ground, but that's what it looked like, if that's helpful.
Thank you. Thanks so much. So, due to a little bit of disjointed people needing to be in multiple places, I know that I promised you that we had no committee this afternoon, but we're gonna come back after the floor. And I'm gonna ask that we be prepared to vote on this 10 minutes after the floor. And since we have another 6 minutes before lunch, let's have Jen start just doing markup, bringing up the language, going through it again, seeing if we have any concerns with it.
Morning, Barely. Jen Harvey, Office of Legislative Counsel. And we'll put, Right. So this is S53, an act relating to certification of community-based perinatal doulas and Medicaid coverage for doula services. Section 1 is the new chapter on community-based perinatal doulas, and I don't know if you want to go through that again or just remember what's in the
Just sort of remember what's in.
a bunch of definitions. Anybody have any questions on the definitions? All kind of.
Does everyone know what a doula is? Okay.
You don't have to be certified to provide doula services in the state. The certification would be voluntary and that somebody would choose to seek certification if they wanted to be providing services in the Medicaid program. I mean, they could seek certification anyway, but that would be perhaps the main reason somebody would. Director has their normal duties, OPR director with respect to a regulated profession. This is an advisor model for OPR regulation. So there would be 2 certified community-based perinatal doulas who would serve as advisors on matters related to the profession. In order to be eligible, the individual would have to be at least 18 years of age, have sufficient and appropriate competencies in community-based perinatal doula services, and they can acquire those through experience, mentorship, training, formal education, or a combination, as determined by the OPR director by rule, and have passed any criminal history background checks or registry checks required by the director. Renewal is every 2 years. Unprofessional conduct means misusing a title or doing any of the things in the OPR unprofessional conduct statutes. And the bill adds community-based perinatal doulas to a few OPR statutes, so just which professions they regulate, which applicants and licensees they can look into their criminal history background checks or into their criminal background histories. The fees, $75 for initial certification, and then $120 biennial renewal fee. Medicaid coverage. This would require DVA to provide reimbursement to a certified community-based perinatal doula for providing doula services, but not provide travel time or mileage expense reimbursement. Legislative intent is for the amounts to be reasonable and adequate for the services provided and consistent with the rate set by other states' Medicaid programs. And I know you talked about the reimbursement methodology from DVA's Senate testimony. Directs DVA to seek a state plan amendment. This is the SPA Alex was talking about earlier. SPA's state plan amendment, separate from the 1115 waiver. And effective dates The certification program would begin on July 1st, 2026, with rulemaking happening before then to make sure the rules are in effect when the certification program starts. The Medicaid coverage would take effect July 1st, 2026, or on the approval date of the state plan amendment, whichever is later, and everything else is effective on passage.
Cover. Certainly questions? Jen?
Is it absolutely a fact that the state plan would, they would have to go to the Centers for Medicare and Medicaid to get
It's a
it?
fact that that is where you go to get an amendment to the state
I know
plan.
that's where you go.
Whether we need one, I defer to Diva's expertise on that. That is not a statutory legal matter. That's a Medicaid policy matter. It's my understanding that we do, because it is not something that is currently covered in our Medicaid state plan. It's not a provider type or service type that is currently included in our Medicaid state plan, which is what lists everything that's covered in our Medicaid state plan. So it makes sense to me that we would need a state plan amendment. But if they said, oh, we think this fits under something we already have in our state plan amendment, I would defer to that as well. They're the experts on Medicaid program implementation.
State plan amendment, seeking a state plan amendment is different from an 1115 waiver, much different. This, as it's been described to me, and maybe you can tell me if I'm right, that CMS has a menu of all sorts of services that states can choose to cover under their state plans. And in order to cover that, the state needs to go to CMS and say, we'd like to include that as well and
I
get
think-
permission.
Yes, roughly that approach. I think this is the difference between state plan amendment and an 1115 waiver amendment is we're not looking to get Medicaid match on federal match on something that the Medicaid program would not ordinarily, absent a waiver of federal law, cover. This is doulas and doula services are covered in a number of other states at this point. It's a known option. So it doesn't require us to ask CMS to please cover something that they otherwise would not cover with Medicaid dollars. It's just saying we would like to add a new Medicaid service
And
to
the
Vermont's Medicaid program.
reason I asked the question is because in here, it says if needed.
Right. And that's because when I was drafting it, I did not know if we needed, this bill, I think, has been introduced a few times in various forms, and we haven't really talked about the Medicaid state plan aspect of it. So anytime we're doing something with Medicaid, or almost anytime, I'll usually put in language saying if needed.
Leslie?
So I'm not sure if you know this answer, but we got testimony this morning that if we open up our state plan, then we open up our entire state plan, and that could all be vulnerable. And that was information I didn't know or understand, and I'm not sure how to figure that out.
I don't know what it looks like when we ask for an amendment to our state plan. I think CMS has full access to our state plan at all times.
All the time.
Yep. It's online. I've looked at our state plan.
Yeah.
So I don't know.
I
don't know if it's a barter process when we're looking to add a new, it's not my understanding that
I think.
that we reopen discussion on every covered service anytime we ask to amend our state plan, but I don't know in reality what that negotiation or conversation looks like.
Woody, did you have a question?
Yes, in our bill, it built up two things, it appears to me, and you can correct me. It allows certification of community-based perinatal doulas, and then it does the Medicaid coverage. I'm fearful of jeopardizing our Medicaid issues, okay? Is it possible to only do certification of community-based doulas and leave out the Medicaid coverage for now?
It's certainly possible. They're not linked together in a legal sense. The whole rationale for having the certification process was in order to provide the Medicaid coverage. So I'm not sure it makes sense to do the certification piece uh,
But it would
for
be,
a subset of doulas.
but it would be a step forward, and then maybe when things calm down.
It would set up, it would set up the potential for certification. I'm not sure if anybody would pursue certification if there was no Medicaid aspect. But no, they are not, if you're looking to, can we just do section 1 and not do the Medicaid, or sections 1 through 4 and not do the Medicaid piece? You can. They're not,
I know that.
it doesn't require the Medicaid.
I know that disappoints a lot of folks, but thinking about the state Medicaid programs is a concern.
Sure. I'm not sure if it's worth it to you or to OPR to go through the certification process at this point. You could connect the timing in a different way to have the certification process, them develop the certification program. Once we got approved for, and put a longer time horizon on when they seek the state plan amendment. So I think there's ways to approach it.
Daisy.
Were there other things that we suggested or required AHS to look at a SPA for this session?
Don't recall, but a lot of bills. I don't know.
I feel like there were, or
I do feel like there was something else.
yeah. So my point is like
Birth centers.
there's a whole.
Thank you. Yes, it was exactly that. Birth centers is to add them as a location in our, approved location in our Medicaid state plan. Thank you.
That was
Does
an
this
issue.
does this require them to, or does it say they?
It tells them they shall if required.
And in their written testimony today, they did say that they determined that it would require that. So,
Which does not surprise me. Yes, they shall seek a state plan amendment if needed to allow the program to cover doula services.
I don't think that's very, I don't think it's uncommon to do a state plan amendment.
It is not.
And yeah, so it's not like it's gonna risk our entire Medicaid program, is my point. That's something that's done from time to time as we change the components of our waiver. That's why there are SPAs. And I think to Leslie's question about, what do you mean it opens up our whole thing? It's just because when they do a SPA, they look at what's actually going on in our Medicaid plan. And if we're going to add something to it, that conversation includes, well, what's in your plan? It makes sense to add this to it. So I think maybe that's.
Sounds like you're.
Well, they look at what's in it and do we add this?
Right.
But
That's what I mean.
it's something that they do regularly. So I don't think, I'm not concerned about adding this. And I totally trust the team who normally leads these conversations to lead the conversation again, as well as judge when the timing is right to start that conversation.
Topper?
I was just going to say that, I agree with you, Daisy. Problem I have is the testimony that we had this morning. Alex was scared stiff about opening it up. But that doesn't mean we can't do it.
And I think I asked him the question, that they were in favor of birth centers, freestanding birth centers, which opened up that as well.
Right, although I do think he made the distinction between the setting for a service that's already covered versus a new service.
Yes.
Yeah.
Okay, so we're gonna come back after the floor, 10 minutes after the floor. I want to put something on the record here. When we started this session and the bills started going up on our wall, we all know financial and fiscal environment that we are in right now. And there are a lot of really, really wonderful bills sitting up on that wall. And there are a ton of them that I have basically just said, I wish, and there is no way I can expand coverage of anything, provide additional services. I mean, a lot of things that you all brought. And I was like, we just can't do it. S53 is the one and only bill that we have even looked at this year that expands coverage under Medicaid, and explicitly over the last 3 years of testimony on this, we know that it will actually have a savings for our Medicaid program. So while people consider testimony that we've taken, just, we've been really, really cautious this year. So I would hope that the committee members would take that into account before we vote on this at 10 minutes after the floor.